Hello everyone. In this lecture, I am going to discuss about the management of postpartum hemorrhage. So we know that it is the one of the leading reason to cause maternal death. So here in this video, I will show you a very simplified flow diagram where you can understand the basic concept, that is what are the basic reasons behind this PPH and how we will manage according to them. So before you watch this video, I will suggest you that you must watch its previous part where I have discussed about its causes and types, because if you correlate with these all things, you must be able to understand its management. And we know that it is the one of the important topic also for exam point of view. So the link of that video is given in the description box here. And in this nursing lectures channel, all my topics are covered in Hindi and English language as well. So you can find this all thing in the playlist. So let's begin with its flow diagram to manage this PPH according to its most common reasons, because there are many reasons, but we will discuss here about its common causes and according to that how we can manage stepwise. Okay, so we know that the PPH is of two types that we already discussed previously, that is primary PPH and the secondary PPH. Primary PPH where the bleeding start after the birth of baby, but it is within 24 hours, and in secondary PPH where the bleeding start beyond 24 hours but within puerperal period. And in primary also we discussed its two types, that is the third stage and true PPH. So as the name denotes, third stage, in this the placenta is not separated yet. Yes, so bleeding start before expulsion of placenta, and in this the bleeding start after expulsion of placenta but within 24 hours. Okay, so let's begin with its management. So whatever the reason is there, whether it is primary or secondary, first we need to do few important steps beforehand. So what all things we can do here, first we will mention these points. Whatever the reason behind this PPH, we will do these all things in any of the condition. So first thing is we just call for help, because this is the one of the very dangerous condition in which we cannot handle this situation alone. So we require the help from various medical persons, like we need to call upon the senior obstetrician, anesthetists, senior nurses. Okay, so along with all these medical person only we can manage this situation very easily. So first the thing is we just call upon the medical persons for help to manage this PPH. Okay, next, once we come to know that the woman is having PPH, we just start two large size IV bore lines. Okay, so why we require two lines? Because here the woman is bleeding heavily, so we need to maintain homeostasis. We need to resuscitate the woman with the fluids. So we require two lines, because one line required for the fluid resuscitation where we can give normal saline or ringal lactate, that is crystalloid solution, to infuse rapidly, and the another line for blood transfusion if required. So we require two large bore size IV line for fluid resuscitation and the blood transfusion. Okay, the third important thing is we just send the blood test for the investigations, in which we need to know about the bleeding time, clotting time, coagulation profiles, as well as we need to know about the fibrinogen level. Women's blood grouping and cross matching is also required, because if we want blood transfusion, then at that time we must know about what is the blood group and what all status of blood values are there. Okay, so we send the blood test of a woman, and then next point is we must catheterize the bladder. why the bladder must be catheterized. This fully loaded bladder is usually interferes in effective uterine contraction. One important thing is that, and the other thing is that the woman is heavily bleeding, so we must know about its urine output, because there may be a hypovolemia, so there may be a less urine production, so we must know about its urine output also. Okay, so next thing is to catheterize the bladder, and the very important thing, side by side we required the full assessment of the vitals. Okay, we must know about the woman's temperature, blood pressure, pulse and respiratory rate also. Okay, so because with this heavy bleeding, what happened, there may be a hypovolemia, and that may cause the low blood pressure as well as increase in pulse rate also. Now once we come to know that the third stage is the reason for PPH, then what we can do, we perform all these steps beforehand, and once the placenta is not separated and we came to know about this thing, then we first go for the uterine fundal massage, because we want uterus to be hard. So first we make the uterus hard to get the placenta separated. So how we can do uterine fundal massaging, that is, we can put forefinger behind this uterine posterior wall and thumb in front, and we will continuously give this uterine fundal massage, because by this only the uterus become hard and then placenta get separated, but it does not happen always. So let's see, suppose after giving this whole intervention and by this uterine massage the placenta gets separated. Suppose placenta separated. So if the placenta gets separated, what happened? Is it come out directly? No. What happened? Once it gets separated, it lie down in a lower segment. So what we can do here is that firstly we can start IV infusion of oxytocin, as well as we can give methergin as well, because these all drugs, these all uterotonics helps in continuous effective uterine contraction. But we must be very careful that if we are administering methergin, then the woman should not have any hypertensive disorder or any heart disease, because it can cause tetanic uterine contraction and vasospasm. Okay, so we must avoid this methergin in hypertensive women. But if the placenta gets separated, we can continuously infuse these drugs, okay, especially the oxytocin, and once it comes down in lower segment, from there we will perform CCT, controlled cord traction. It means when the uterus is contracting, at same time only we can pull the cord, or we can give traction to the cord to expel out it completely. Okay, so once it gets separated, placenta gets separated, by CCT only we can pull the cord out, and simultaneously we will infuse the oxytocin drug also to make the uterus contract continuously and to stop bleeding further. Okay, and once it will comes out, that is the placenta comes out, what we can do next, that is we just check it for its completeness. Because we must be sure about that nothing is left behind in uterine cavity, whether it is the fetal tissues, cotyledon or any fetal membrane. Okay, it does not happen in every situation where by the fundal massage alone only the placenta gets separated. So what we can do, we will check if the placenta is not separated after giving this continuous uterine massage also, then what we can do, we'll try to manually remove it. We'll try its manual removal. So this could be done under general anesthesia or deep sedation. So how we can manually remove this placenta? First we use our dominant hand, that should be gloved and lubricated, and in a cone shaped manner we introduce in the vagina and in the uterine cavity. So by this manner, in a cone shaped manner, once we place in the uterine cavity, we just locate the placenta and place the finger in between the uterine wall and the placenta. Now slowly we will do a slicing movement, and by the slicing movement the placenta gets separated. Yes, and once we sure about that the placenta gets separated completely, it comes down in a lower segment, and by the other hand we will slowly give traction to the cord and remove this placenta or expel out its completely. And the hand which is still left in the uterine cavity is generally used for any left behind tissues, cotyledon, or any other fetal membrane. So once we ensure that there is nothing in the uterine cavity, then we will remove this hand also. Okay, so again, once the placenta gets separated manually, after that also we will check its completeness, okay, to further stop bleeding. Okay, so these are the steps to manage the third stage where the placenta is not separated. Okay, so rather you can give fundal massage, or if it is not separated, then we will perform manual removal. Now what will happen in true PPH? We know that in primary there are the most common reason behind this primary is the atonic uterus or the trauma, because these are the reason which can cause heavy bleeding once the placenta gets separated, but that could be appear within 24 hours. Atonic uterus means the tonicity of the uterus is completely lost here. It means the uterus is feeling flabby or boggy. Okay, so uterus feels flabby here. So once we come to know that the uterus is atonic, then we will go for all these preliminaries. We must do all this thing, and then we will do uterine massage, uterine fundal massage. We'll try to make it hard by the fundal massaging. But suppose after giving this uterine fundal massage also, if it fails, then we will go for the drugs, that is the uterotonics. So what all drugs are there to make the uterus hard? The first line of drug is the oxytocin. So first we will infuse. Oxytocin is usually given by the IV infusion, about 20 units, infusing in 500 ml NS. Okay, but never this drug to be infused IV bolus, because it can further cause hypotension. Okay, so first line of drug is the oxytocin, that could be infused by IV infusion. And after giving this drug also, if the uterus is not contracting yet, then we will move on to the another drug, that is methergin. Methergin, that is ergonovine or ergometrin, whatever you can say. So methergin is to be given about 0.2 milligram, and this could be given intramuscularly or you can give intravenously. Okay, so if methergin is not working yet, it is not making the uterus hard, then what we can do, we will go for the another drug, that is misoprostol. So misoprostol is the prostaglandin even analog, and that could be administered about 800 to 1000 microgram rectally. This drug can be administered orally, sublingually, rectally, pervaginally, but here we will prefer rectally, because pervaginally is not possible as the woman is bleeding, and woman is heavily bleeding, so she may be lethargic, that she may be unable to take orally. So a rectal route is most preferable in the misoprostol drug. But suppose after giving all these three, the still uterus is not contracted, still it is feeling flabby, then the next drug which we can administer is the 15 methyl PGF2 alpha analog, that is carboprost. we can administer. So carboprost can be administered about 250 microgram intramuscularly is to be the route of choice, and maximally 8 doses we can administer with the 15-minute of interval in each dose. Okay, so this would be the next drug of choice, but again we must be cautious about its use because it cannot be used in asthmatic women. So carboprost could be given by 250 microgram, but we cannot wait for whole 8 doses to be complete. It is not like that if oxytocin infusion is fail, uterus is not contracting, you are moving toward the methergin, then you are giving misoprostol, and then you need to wait for this whole 8 doses to complete. No, it is not like that, because already it is consuming too much time and we are not in that state that we can waste few more minutes. Okay, so in 2 to 3 doses of this carboprost also, if the uterus is not contracting, then we cannot wait for these whole doses to complete, we move on further. Okay, so what is the next step? Once the uterotonics fail to contract the uterus, then the other choice is the uterine compression. So how we will make the uterus compressed? By the bimanual method. Bimanual compression. So what is bimanual? Bimanual means you are using both the hand. Like if you are using one hand to massage the uterus, like in same manner as I told you in the fundal massage, forefinger behind the posterior wall and thumb in front, and make the uterus steady, yes, so that it will not move, and use your another hand that to be placed inside the vagina and compress its the uterus anterior wall. So by these two hands, like one hand is busy in doing fundal massage and the other hand is compressing by making the fist form, you can introduce your other hand and compress the anterior uterine wall. So when you are using both the hand, what you are doing? You are compressing both the walls of the uterus to making it opposed to each other. Okay, so you are opposing both the walls to each other, and once you oppose both wall each other, what will happen? The open sinuses will compress, and by this method, by compressing the open sinuses, you are stopping the bleeding. Okay, so this is the method where the uterine compression could be given. But still, if it is failed, then what you can do next? That is, you can use uterine tamponades. Uterine tamponade is the same principle that we are using in the bimanual compression method, but here what you are using the balloons. Okay, so one very common balloon which is usually used in this situation is the Bakri balloon. So this is a balloon like structure, and we are introducing in the uterine cavity in deflated manner, and by this balloon there is a one catheter which is attached, and by this catheter we are infusing about 200 to 500 ml NS once it rests in the uterine cavity. So this deflated Bakri balloon become inflated in the uterine cavity by the normal saline, and there we will kept it for about few hours. And what it does, this Bakri balloon, once it becomes filled with the normal saline, it compresses the uterine wall again. So the open sinuses become compressed and bleeding thereby stops. Okay, so there is one advantage is there in Bakri balloon. Once it filled with the normal saline and it occupies whole uterine cavity, one draining tube is also there which rests in the uterine cavity, and that will not allow any blood to rest in that space. So if still there is any bleeding, this draining tube allows the blood to escape out. Okay, so the blood is not still collected in the cavity once the balloon is filled up with the normal saline. Okay, so this Bakri balloon is usually expensive, and if you want to do that procedure in a least cost, then the other method is the use of condom. So condom catheter is the other choice because it is not that much expensive, and we will perform this whole procedure in same manner as in Bakri balloon. Like we will use condom in a deflated manner, and we will tie it by the Foley's catheter, okay, and in deflated manner we will introduce in the uterine cavity, and by this Foley's catheter we can infuse normal saline, okay. So again that will fill the uterine cavity in a balloon manner, and that will compress the open sinuses and stop the bleeding. After giving all this uterotonics, the bleeding is not stopped, the uterus is not contracted yet. After bimanual compression also the uterus is feeling flabby. We tried balloon tamponade also and still it is failed. Then the next choice is the surgery, that is the surgical method. But there are the two things in the surgery, that is, one is the uterine compression sutures. First go with the uterine compression suture, and the next step in surgical method is the stepwise devascularization procedures. And in compression sutures there are various techniques, like like B-Lynch sutures and Heyman sutures. These are the different techniques to suture the whole uterus to make it hard, and the Cho's square suture method, okay. But the most commonly used is the B-Lynch technique, where this suture technique is suggested by the B-Lynch. So here I am not going in detail, but what this B-Lynch suture does, it will compress the uterus by this suture, and by this compression the uterus become hard and further the bleeding stops. Because the basic thing is, once the open sinuses become compressed, okay, and thereby only the bleeding stops. So in this B-Lynch technique, one suture is placed just beneath the incision, and that will form a loop around whole of the uterus about 2 times, okay, and then we are just placing a knot just below the incision. Thereby this loop which is forming around whole of the uterus is compressing the uterus and make it hard, so thereby only the bleeding stops. So this is the most effective method in the surgical method. If you want to stop bleeding fast, then this is the ideal method to be used. But still, if it is not contracting, then the doctors usually perform the stepwise devascularizing procedure, where the stepwise major arteries are ligating. So what arteries are ligating here? That is, first bilateral uterine artery ligation. It means the uterine artery which supplies the uterus is tied up, okay. Bilateral means both side, okay. Then the next step is the bilateral ligation of ovarian artery. The next artery which is to be ligated is the ovarian artery, both side, and the anterior division of internal iliac artery. So the next artery which is to be ligated is the anterior division of internal iliac artery. So kept in mind, this is the anterior division. If the posterior division is ligated, then the supply to the lower limb be hampered. And after performing all this surgical technique also, the still uterus is not contracted, then the last option after that is the hysterectomy. So hysterectomy is the last option, where we must remove this uterus completely or partially to stop bleeding, okay. But this is the last option, but beforehand we will go with these steps to make the uterus hard, which is flabby, okay. So these are the line of techniques where we will stop the bleeding in the atonic uterus. But suppose the reason for this bleeding is the trauma where any tear is there in the genital tract, rather in the cervix, in vagina, in perineum or in uterus. So if the trauma is the reason for the bleeding, then what we will do, we will explore under good vision, good lighting. So explore the whole structure under general anesthesia, and then what we will do, we will suture it. So wherever the tear is there, we will suture it up. Okay. If the reason for postpartum bleeding is the secondary PPH, where the bleeding is appeared after 24 hours of delivery of baby, then we already discussed the most common reason behind this is the retained tissue. Okay. So what we will do in this situation, we will explore again, we will explore under general anesthesia or deep sedation. So we will pick up these all retained tissues by a forceps or any curette. So this is how, by exploring whole the uterine cavity under general anesthesia or deep sedation, we will remove all the retained tissue. So that will add in further contraction and will stop bleeding, because these retained tissues interfere in effective uterine contraction. So here in this lecture, we have discussed the management of postpartum hemorrhage in a diagrammatic manner. Thank you.